This is an MRI on an 80-year-old male patient who presented with dementia. As we learned from prior sessions, this is the ventricular system, which on such a T2 weighted image appears bright. So this is a T2 weighted image showing CSF spaces, whether in the ventricle or outside them, as bright on T2. To make things easier, you could look at this image here, which is also a T2 image with a twist. So on T2 weighted images, the gray matter looks white, the white matter looks gray, as we learned from before. Abnormalities of the white matter would appear bright. And on this sequence, which is also a T2 as we mentioned, the fluid is suppressed. It appears dark. This is called a flare sequence. So it's basically a T2 sequence suppressing the CSF brightness, which makes detecting lesions easier. This is a good case for radiology residents and neurology residents, but I think students and juniors would find something useful out of it. For students and interns, you'll learn an important new entity by going through this clip. So we agreed this is a flare image of the brain. This is anterior, this is posterior, right and left, and it's as if you're looking at the patient from his feet. The first thing you notice is that the brain seems to be atrophied. The volume of the brain is less than expected. This is something that we commonly see when compared to younger brains. You have a more pronounced appearance of the CSF spaces and a decrease of the volume of the brain. A finding that's not surprising in an 80-year-old male patient. The issue arises here from the pronounced appearance of the ventricular system. This is a larger ventricular system than what you expect. The question is always, is this dilatation of the ventricular system, or is it related to a more pronounced appearance due to volume loss? A very simple and subjective way to answer that, ask yourself, is the ventricular size proportionate to the volume loss? Meaning that the ventricular size should be corresponding to the degree of atrophy or volume loss that you see with aging. Of course, you need some experience to decide whether the ventricular size is proportionate or disproportionate to the atrophy. With this case, it's a bit easier since the ventricle really seems larger than expected. Now, there are other signs to look for if you're not sure. The first thing to make sure of is that there is no obstructive lesion that leads to such dilatation of the ventricle. In this case, the lateral ventricles are dilated, the third ventricle is dilated, and although the fourth ventricle is relatively within normal size, there is no obstructive lesion. This thin linear dot is actually the cerebral aqueduct of Sylvius that connects the third with the fourth ventricle. So now we made sure that there is no obstructive lesion, and if what you're looking at here is true, this is a form of non-obstructive or what we call communicating hydrocephalus. The entity that you will learn today is called normal pressure hydrocephalus, NPH. This is a type of non-obstructive hydrocephalus that is typically seen in elderly patients, well known but not clearly understood. There are many theories of why this develops, but the easiest way to understand this is that the CSF dynamics are disturbed. By that we mean that the secretion of CSF may be abnormal, the absorption of CSF may be abnormal, or both components may play a role. Such dilatation of the ventricular system may lead to symptoms, typically nonspecific. But some patients present with a classic clinical triad of dementia, gait abnormalities, and urinary incontinence. So on imaging, when you see ventricular dilatation that's disproportionate to volume loss in an elderly patient, that's something you could think of. However, don't overcall this entity since lots of patients have volume loss and more pronounced ventricles without having the disease. And it's extremely important to correlate the image with the clinical presentation, since if this is a true finding, treatment may be effective. When normal pressure hydrocephalus is correctly diagnosed, shunting or lumbar puncture may improve the patient's presentation. Now, for more senior audience, are there some signs that could help us be more confident about the diagnosis when it comes to imaging? And yes, there are a few non-specific signs, but they're useful if seen in combination with a disproportionately dilated ventricle. First, with increased pressure in the lateral ventricle, you may have CSF that passes into the brain. And this is what we call transependymal CSF permeation. This white area here around the ventricle, the periventricular hyperintensity, represents this CSF permeation phenomenon. Another sign that might help you is that despite the volume loss, you still have fullness at the brain convexity here. With atrophy, you'd expect to see more CSF space in the form of sulci, which is not really the case here. So this tells you that this is a full convexity. And this is a sign that makes sense, since the dilated lateral ventricle pushes everything upwards and leads to this fullness here. And as it does that, it lifts the brain upwards and gives you a more dilated appearance of the sylvian fissures here, as well as a more pronounced appearance of the basal cisterns or the cisterns surrounding the brainstem. Here's a sagittal T1 weighted image from the MRI of the brain of the same patient. So this is a T1 image. As we learned before, the T1 image shows you fluid or CSF as being black. And with T1 images, the gray matter looks gray and the white matter looks white. So that's one way to differentiate between this and the FLAIR image that I showed you. The image is slightly degraded by motion artifacts since the patient had some dementia and couldn't follow orders, but it's still a diagnostic image. So we see the dilatation of the lateral ventricle, the dilatation of the third ventricle, the fullness of the basal cisterns, no obstructive lesions at the cerebral aqueduct with a relatively normal fourth ventricle here. Another interesting finding that you could see here is the scalloping on the brain, which you see here as well as everything is pushed upwards. Sometimes this is associated with thinning of the corpus callosum, which is mildly thinned here. And another point that we mentioned on the axial image, despite the volume loss, there is fullness of the brain at the convexity. So let's summarize what we talked about. First, we talked about T2 weighted imaging where fluid and CSF is bright. A modification of T2 is by suppressing the fluid or CSF, which we call FLAIR, which makes white matter abnormalities more clear. FLAIR may confuse you with the conventional T1 where fluid is black, but an easy way to differentiate is to look at the gray and white matter. On T1, gray is gray, white is white, while that is the opposite on T2 or on FLAIR. There's an entity that represents a form of non-obstructive hydrocephalus seen in elderly that's known as normal pressure hydrocephalus, with the classic Hakim triad of dementia, gait abnormalities, and urinary incontinence seen in some patients, and where LP or shunting may be therapeutic if the diagnosis is made correctly. Correlating the image with the clinical picture is the most important, so don't overcall this entity. On imaging, it's a bit tough to diagnose because elderly patients would have atrophy, and the hint is to find disproportionate dilatation. In addition to that, try to look for fullness at the convexity, pronounced appearance of the sylvian fissures and the basal cisterns, as well as features of CSF permeation. Remember that normal pressure hydrocephalus affects the lateral ventricle and the third ventricle with a relatively normal fourth ventricle. So always make sure that there is no obstructive lesion. That changes the diagnosis from non-obstructive to obstructive hydrocephalus. That's the end of this case of normal pressure hydrocephalus. Thanks for watching and see you with more cases later. Hello everybody. This is a neat case with good teaching points for both seniors and juniors. This is a hepatic ultrasound image of a 27-year-old male patient who presented with nonspecific lower abdominal pain. The image concentrates on the left hepatic lobe. This is normal liver, and there is this focal area of abnormality. So it's a well-defined focus of decreased echogenicity, what we call hypoechoic. Whenever such a thing is seen, we apply Doppler to assess for vascularity, and not much vascularity was there. So a CT scan of the abdomen was performed dedicated to assess the liver, starting with a pre-contrast image. So without IV contrast, there is no obvious focal abnormality within the liver. Here's the CT repeated after giving intravenous contrast and imaging the liver early in the arterial phase. For less experienced viewers, you could tell that this is an arterial phase by seeing the extremely dense contrast within the arterial structures, and by the lack of contrast in the venous structures, for example, the portal vein here. So notice a dense aorta and no contrast in the portal vein. Now that we did that, you could see the focal hepatic abnormality. Note how the lesion is faintly seen, and this is an important teaching point. You have to switch to a liver window, a very dark window, to see it. And this is after switching to hepatic window. You see this hypervascular focus that's well defined and corresponds to the ultrasound image. Again, the lesion is well defined and homogeneously enhancing on this arterial phase. Now a little bit of anatomy on this arterial phase CT. If you go from above below, this is the aorta. Going lower down, the first branch you'll see is this big branch here, which is the celiac artery. Then below that, so this is again the celiac artery above. If you go lower down, below that you see the SMA, the superior mesenteric artery. And the SMA has this characteristic dip into the mesentery. Going all the way lower down, you'll see a small branch here, which is the IMA. So the inferior mesenteric artery is a small vessel that arises a bit lower down compared to the celiac and SMA above. Let's go to the celiac artery again. The celiac artery classically divides into three vessels: the splenic, hepatic, and left gastric. So here's the splenic artery heading towards the spleen. That's easy to see, it's a big vessel. And this is the common hepatic artery arising from the celiac as well, and heading all the way towards the liver. And finally, the one that's a bit smaller is this branch here, which is the left gastric artery. It goes to the stomach. Now, why am I showing this? I want you to concentrate on the common hepatic artery and see how it goes to the liver here. To simplify things, we know we have a right and a left hepatic lobe. So the hepatic artery proper should divide into a right-sided and a left-sided hepatic branch. In this case, if you follow the celiac, the hepatic artery, you'll notice that you only have a right-sided hepatic branch. However, the left-sided hepatic branch arises differently high above here and runs within this fissure here. So if you follow it all the way back, you'll notice that it arises from the left gastric artery instead of arising from the hepatic artery. This is a very common variant, which is called a replaced left hepatic artery, arises from the left gastric instead of the hepatic. Such vascular variations are significant when it comes to treating hepatic lesions, whether by endovascular or surgical options, and should be mentioned in your report, since that's a very significant piece of information to the sending physician or the surgeon. Now, a simple solution to identify this for juniors is that look at this fissure here. This is the fissure for the ligamentum venosum. You should have no vessels running there. If a vessel is seen there, this is either a replaced or accessory left hepatic artery. A piece of information that may be relevant is that this replaced left hepatic probably supplies the lesion here. Here's another look at that vascular lesion on the hepatic window with this replaced left hepatic heading towards it. Now let's proceed with the CT on the same patient acquired a little bit later when you have enhancement of the venous structures. So this is a portovenous phase. The lesion has disappeared on the portovenous phase and you don't see it even if you change to a hepatic window. Here's a later phase as well, known as a delayed phase, usually taken at 3 to 5 minutes after giving contrast. And the abnormality is not seen as well. Now let's go back to the arterial phase and talk about a few pertinent negatives. First, the liver is homogeneous in density apart from that focal area of abnormality. It does not show an additional lesion, and it does not show decreased liver density, which could go with hepatic steatosis or a fatty liver. More so, the hepatic contour is very smooth with no irregularity to suggest fibrosis or cirrhosis. Very importantly as well, the lesion does not cause any compressive or mass effect, and there is no biliary tree dilatation. Finally, the rest of the examination was normal with no lymphadenopathy, ascites, or other features. Now, before we discuss the most likely diagnosis and the differential diagnosis of such an abnormality, I'll show you the MRI quickly. We will apply the same concepts of enhancement when we look at the MR image. This is a T1 weighted image where fluid is dark and the lesion is not seen in the expected location. These circles here are just artifacts, by the way. This is a T2 image where fluid is bright. Notice how the gallbladder is bright and the lesion is also not seen on this acquisition. Here's another T1 image with fat saturation, meaning that we are suppressing fat signal so it appears dark. And again, the lesion is not well seen. Now this is another fat suppressed T1 image after giving contrast, and juniors, you're experts now. You could tell that this is an arterial phase. You know that by the bright enhancing aorta and related branches without enhancement of the venous structures such as the portal vein. And as expected, this lesion is hypervascular and homogeneously enhancing with a well-defined border on this phase. Now to another T1 fat suppressed image at a delayed time showing enhancement of the venous structures. This is the portovenous phase. On this phase, the lesion is not seen. The contrast has disappeared. So I showed you what I wanted to show you on MRI. Let's go back to the arterial phase on CT where the lesion is more pronounced. Now, what are the possibilities for such a lesion? The appearance is almost classic, but we'll go over several considerations. Can this be the very common benign hepatic hemangioma? Now, hemangiomas are typically seen on the pre-contrast image as hypodensity, and they fill progressively from the periphery. Another feature is that when they fill, they have the same density as contrast within the blood pool, which is not the case here. Since they're fluid containing on T2 MRI, they would have been easy to see as very bright structures. So this is not a hepatic hemangioma. Now, can this be the very common as well hepatocellular carcinoma? You usually see hepatocellular carcinomas in cirrhotic livers, which we have no features of on this case. You typically see them as either homogeneous or heterogeneous lesions on the pre-contrast, and you'd see them on the post-contrast as hypodense abnormalities. So you'd see hepatocellular carcinomas typically on the portovenous phase as hypodense abnormalities after contrast has washed out. Even if the liver is not cirrhotic, you want to make sure that the patient does not have a risk factor for HCC such as hepatitis B virus. All of that was absent here, so this is not a hepatocellular carcinoma. What about the lesion known as fibrolamellar hepatocellular carcinoma? Well, it's a very rare tumor that occurs without risk factors for HCC, so you could see it without fibrosis, classically in younger patients. But speaking about what's common and what's rare, this is a very rare lesion that you could pass your whole career without seeing a single one of them. So fibrolamellar HCC could appear homogeneous or heterogeneous. You would see it on other phases, and it typically has a central scar. Again, this is not a fibrolamellar hepatocellular carcinoma. Can this be a hypervascular metastasis? Remember, metastasis is common. Now, typically with metastasis, you'd know that the patient has a primary tumor. And you typically see metastasis as hypodensity on almost all phases. Even in the less common hypervascular metastasis where the MITS enhances strongly on arterial phase, you'd see it on other phases. Renal cell carcinoma, which is a very vascular tumor, is a good example of hypervascular metastasis. In this case, none of that is present, so this is not MITS. Another hypervascular entity that you may think of is a hepatic adenoma. Although hepatic adenomas may be small, they're typically large and heterogeneous because of hemorrhage necrosis and sometimes calcifications. They're not the most common hepatic lesions that you'd see, but they're typically seen in a specific subset of patients. Adenomas are usually seen in females, and typically females on oral contraceptives. They may be seen in males on anabolic steroids or patients with glycogen storage disease. Given the large and heterogeneous appearance, you'd likely see them on other phases. So all of that was absent here, and this is not a hepatic adenoma. We're left with one choice for hypervascular hepatic lesions, and that's called a focal nodular hyperplasia. Focal nodular hyperplasia is a lesion that could be seen in males, but it's way more common in females as well. It's basically a reaction to a vascular abnormality of the liver, and that's why it's a vascular lesion. You could simplify this by remembering that this is a hamartoma or a hamartomatous reaction. For juniors, remember the difference between hamartoma and teratoma. Hamartoma is exaggeration of normal tissue in a normal location, while teratoma is exaggeration of normal tissue in abnormal locations, such as seeing a teratoma in the ovary where you have hair, teeth, and bone. Focal nodular hyperplasia, FNH, is the second most common benign hepatic lesion. FNH is typically seen in females of mid-age, but could be seen in males and at different age groups. It's usually a small lesion that is well defined, does not typically exceed 4 or 5 centimeters, usually only seen on arterial phase as a hypervascular and homogeneous abnormality. The lesion is isodense in other phases, meaning that it has the same color of the liver, but it might show some hypodensity, especially if the lesion is larger. So your best bet to see the FNH is a good arterial phase on CT or on MRI. On ultrasound, it's typically isoechoic to liver, so it looks like the liver, but it could be hypoechoic or hyperechoic. Our case was hypoechoic. This is another lesion that might have a hypodense central scar that would show enhancement on the delayed acquisition, since fibrosis enhances later. If you see a scar, you might think about either the very rare fibrolamellar hepatocellular carcinoma or FNH. A small piece of information for seniors: if you see a scar for FNH, it would be a bright scar on T2 on MRI imaging, while the fibrolamellar carcinoma scar is typically described as hypo-intense and dark on T2 MRI imaging. So this was a neat case of focal nodular hyperplasia. A few highlights of what we learned today. First, when you're looking at the liver, you need dedicated imaging. To be able to characterize lesions, you need a pre-contrast, arterial phase, portovenous phase, and a delayed phase. Second, whatever phase you're looking at, you have to look at a darker hepatic window, because some lesions would be missed if you don't do that. Third, we talked about the differential diagnosis of a hypervascular hepatic lesion. This includes hemangioma, hepatocellular carcinoma, fibrolamellar carcinoma, adenoma, metastasis, and FNH. Fourth, to be able to differentiate those, you're going to look at the enhancement pattern and the density or intensity on CT or MRI. But you should also concentrate on pertinent information such as the presence or absence of liver cirrhosis, risk for hepatocellular carcinoma, known primary tumor, patient's age and sex, the patient's medications such as oral contraceptives. So a good combo of clinical and imaging parameters to help you reach an accurate diagnosis. We talked a little bit about FNH, and we learned that they're benign lesions, they're common, and they're vascular, typically homogeneous, and may have a fibrous scar that enhances on late imaging. They're typically small and asymptomatic, and this case is a good example of that. We also said that they're a hamartomatous reaction to a vascular insult. While doing that, we learned the difference between a teratoma and a hamartoma. We also learned a little bit about vascular anatomy in the abdomen, and we emphasized the point of talking about variations that are important to the surgeon. From above below, you have the aorta, then you have the celiac artery, SMA, finally lower down the IMA. The cilia gives you the hepatic artery, splenic artery, and the left gastric artery. A replaced left hepatic artery could arise from the left gastric artery and typically runs within the fissure for the ligamentum venosum. One more observation to finalize this case. Note how this replaced left hepatic artery reaches all the way to the lesion. And it appears that this replaced left hepatic artery is the main arterial feeder to this vascular FNH. Now that we reached the end of this case, I would like to thank you for watching. I would appreciate your comments, and let's see you with more cases later.